My name is Professor Xavier Leleu. I'm head of department of hematology, specialized in myeloma, multiple myeloma, in CHU Poitiers in France. And so at ASCO and EHA 2024, I have made two talks. The number one is the benefit study, a so-called IFM 2020-05, which is an attempt to improve newly diagnosed multiple myeloma patients transplant ineligible, and to improve MAIA, the triplet daratumumab-based regimen, daratumumab, lenalidomide, dexamethasone. And so to improve MAIA, we have implemented a quadruplet-based regimen, keeping the CD38 immunotherapy. Instead of daratumumab, we've been using isatuximab, lenalidomide and dexamethasone, plus the proteasome inhibitor, bortezomib, a proteasome inhibitor that all the physicians in myeloma, and I guess all the patients know. So the results of MAIA, alongside IMROSE, the two phase 3 studies that have studied quadruplet versus triplet, the study benefit have provided, I would say, incredible data. Our primary endpoint was the MD negativity rate at 10 to minus 5 at 18 months. And the results is that in the quadruplet-based regimen, isatuximab, bortezomib, lendex, 53% of the patients had a negative MD rate at 10 to minus 5 at 18 months. And 30% of them, approximately, were actually even negative at 10 to minus 6, which is much deeper, much more difficult to get. We don't have survival yet, it's too immature, but there is survival for IMROSE, the results of IMROSE being very close to benefit. The safety profile is great, it's good. It's slightly more problematic when you add the bortezomib, more thrombocytopenia, slightly more neurotoxicity, peripheral neuropathy, slightly more edema of the lower limbs. However, besides this, we believe it was very, very manageable. One particularity of benefit, which is different from IMROSE, was that in benefit, the Velcade was given weekly for 12 cycles, 1, 8, 15, of cycles that are 28 days long, and from 12 to 18 months, it was given 1, 15. And we believe this way of giving the Velcade provided incredible data and was pretty safe for the patients in the quadruplet-based regimen. That's for benefit, and we think that IMROSE and benefit, the two phase 3 studies looking at this quadruplet, isatuximab, bortezomib, lenalidomide, dexamethasone, are going to become now the new standard of care for patients newly diagnosed with myeloma, transplant ineligible, 65, 79 years old. Point number one. Point number two, the second study was many of you patients have an early relapse after line 1. And the question is how to give you a good treatment in line 2, a good treatment that will not oblige the patient to constantly come to the hospital forever until sadly you become progressive on myeloma. So in line 2, in the CAR-MMA2 2B cohort, we have selected patients that were transplant ineligible upfront, that relapsed within 18 months from diagnosis. And in second line, we gave these patients the CAR-T named ide-cel, Abecma, which is a CAR-T that you know targets BCMA. 31 patients were recruited in that phase 2 single-arm study, and 70% of them were in complete response. And extremely interestingly, these 70% that were in complete response, actually only 3.2% had a complete response upfront. But 70% got a complete response with the CAR. Vast majority of the complete response were MD negative. And now, with more than 2 years follow-up, there is the median PFS has not been reached yet. Similarly, the median overall survival has not been reached yet. And the safety profile was actually impressively good. So it tells this second study, as a summary, gives us a lot of information. Number one, it is not difficult to offer CAR to patients that are elderly. Number two, you can very nicely rescue patients who, in a certain extent, failed line 1 with a line 2. Number 3, you can rescue patients with a CAR. Number 4, the quality of life of the patients was, as you know, with the CAR, absolutely amazing. So I hope you will benefit from this treatment. And I think it's a great treatment for line 2 in patients transplant ineligible and more elderly.